Hello once again, class. So, a good day to all of you. So, we are going to continue with what we have left off last year, and a great happy new year to every one of you. So, we'll continue with the rest of the systems, starting on the drugs that are acting on our endocrine system. So, we'll start out first with adrenocortical drugs. First, we talk about the glucocorticoids. We have the short acting ones, the cortisone acetate, hydrocortisone, Cortef or hydrocortisone. Intermediate acting, we have methylprednisolone, prednisone, and the long acting ones, beclomethasone dipropionate, betamethasone, and dexamethasone. As you can see here, all of these drugs, our corticosteroids, they always end in own or zone. Own or zone. Always remember that. These are our corticosteroids. And what are they used? What are these drugs for? These corticosteroids. These are drugs that are used for short treatment of inflammatory disorders. So let's say, for example, you have asthma, you have inflammation that is happening in your body, severe allergic reactions, and others. This is Some of these can also be used as treatment for cancer and replacement therapy for those who are experience adrenal insufficiency. So these are what these drugs do. And when giving these kind of drugs, our nursing considerations is we need to watch out for hypokalemia since they can lower down the serum potassium levels. So we need to watch out for that because hypokalemia can lead to cardiac arrhythmias. And assess for other side effects of glucocorticoids or corticosteroids when therapy has lasted for more than 10 days and the drug is taken in high dosages. And we need to caution this patient not to abruptly stop the drug. When the drug is continued, dose is tapered off within over the next 1 to 2 weeks. When we say tapered off, the doctor is going to gradually decrease the drug dosage until eventually the patient will no longer take it. And avoid persons with obvious infection, because these drugs, they can suppress the immune system. That's why long-term use of corticosteroids can lead to immunosuppression. And if patients who are taking corticosteroids have been taking it for a long time, we need to teach the patient to avoid people with infection, avoid going out to crowded areas, avoid eating raw fruits and vegetables or any kind of food in order to avoid infection. Next, we have mineralocorticoids. We have fludrocortisone. This drug is used to treat also adrenal insufficiency or Addison's disease, and high protein diet is needed when taking this drug since it can cause a negative nitrogen balance. So, one of our patient teaching when giving fludrocortisone is to tell them to eat foods that are high in protein, such as meat or meat products. So aldosterone and fludrocortisone, these drugs increase sodium reabsorption in the renal tubules and increase potassium and hydrogen excretion, leading to water and sodium retention. So again, these drugs, they're used to treat adrenal insufficiency. Now we go to the thyroid and parathyroid agents. With the thyroid hormones, we have thyroid desiccated, levothyroxine sodium, liothyronine, Liotrix. These drugs, they are used to replace hormones in patients who are suffering from hypothyroidism. And remember, you're going to study more of this when you are already in third years, all of the different endocrine disorders. For a patient who has hypothyroidism, remember, if they have insufficient hormones or thyroid hormones, the effect is that their body's metabolism is going to slow down. And the consequences of having a slow body metabolism would be the accumulation of fat. That's why people who have hypothyroidism, they will experience weight gain. And aside from that, you will see that their skin is cold touch. What else? Their vital signs are, some of them are lesser than normal. So that's what hypothyroidism is. And the exact opposite of hypothyroidism would be hyperthyroidism. If a person who has hypothyroidism appears fat, the opposite will happen for patients who have hyperthyroidism. They will appear thin or underweight. Because remember, these hormones, they are responsible for the metabolism. And if they are increased in levels in hyperthyroidism, it will burn too much um, of the calories that the person is eating. Tendency, their skin is warm to touch, their vital signs are increased, and they will not gain weight, they will lose it instead because of excessive thyroid hormones. And you can also observe that their eyes are protuberant, meaning their eyes seems like it's popping out of their eye sockets. So antithyroid agents are the following: propylthiouracil. This is the most frequently used thiamine. And take note, this is the only one that is safe for pregnancy. I repeat, PTU is the only one safe for pregnant women. Also, we have methimazole and other iodine solutions, such as radioactive iodine. They can destroy thyroid tissue in cases of severe Graves' disease. Graves' disease is, or this can happen if hyperthyroidism becomes complicated. Another one would be potassium iodide, thyroblock. It prevents the thyroid from producing thyroid hormone by oversaturating the thyroid cells with iodine. So if there's too much iodine that is detected by our body, the thyroid gland will think that there's enough, so it will no longer produce these thyroid hormones. Remember, the thyroid hormones, they depend on iodine for them to be produced. So take note, potassium iodide is administered after meals. And if you're giving the liquid form, make sure that the patient will sip it through straw to avoid teeth discoloration because it can cause teeth discoloration. So, nursing considerations for patients with hypothyroidism, we need to teach them to avoid foods that can inhibit thyroid secretion. I'm not sure if this has already been discussed in your nutrition subject, but there are certain foods that will cause or that can worsen hypothyroidism. What are these foods? They are the goitrogenic foods, or the cruciferous vegetables. Cruciferous vegetables are the following examples: we have cabbage, lettuce, you have cauliflower, broccoli, artichokes. These are examples of cruciferous vegetables. And if they are experiencing or they have hypothyroidism but they still want to eat these vegetables, since they can also be beneficial, they can provide extra fiber and so on, our teaching is that they should add iodine to their diet, such as using iodized salt if they want to eat cruciferous vegetables, because these kinds of foods will lower down the iodine, or they can inhibit rather the thyroid secretion from the thyroid gland. But for patients who have hyperthyroidism, it's the opposite. If we are going to recommend the usage of iodized salt for patients who have hypothyroidism. We are going to advise patients to avoid using iodized salt in patients who have hyperthyroidism. Next, we have the antihypocalcemic agents. We have calcitriol, vitamin D, and dihydrotachisterol. These are drugs that are used to treat hypoparathyroidism. Remember, calcitonin, which is produced by our parathyroid glands, they are needed in order, or this hormone is needed to um, promote calcium balance in the blood. Now, if there are antihypocalcemic agents, we have antihypercalcemic agents. As you can see here, they always end in dronate. Biphosphonates such as etidronate, ibandronate, and alendronate, these drugs slow or block bone resorption, and they are used to treat patients who have Pagets disease or osteoporosis. So these are the antihypercalcemic agents. Now we go to diabetes mellitus, the antidiabetic agents. So we start out with diabetes mellitus type 1. As you all well know, diabetes mellitus type 1, there are two types of diabetes. We have type 1 and type 2. Which one is the adult onset? Adult onset diabetes is diabetes mellitus type 2, while juvenile onset is diabetes mellitus type 1. And you have for type 1, this commonly occurs or start rather during childhood. That's why it's known as the juvenile onset type of diabetes. These type of people or patients of type 1 diabetes mellitus, they do not or they are not prescribed with oral hypoglycemic agents. They will rather inject insulin for life. And these are the different types of insulin, commonly used insulin products for patients who have type 1 diabetes mellitus. These can also be used for type 2 diabetes mellitus, but it depends. It's a case to case basis. But for type 1, these are the ones used. And what I want you to take into consideration here is its peak. Its peak hours, such as example, regular or Humulin R. The onset is around 30 to 60 minutes, so this rapid acting insulin. Peak is around 2 to 4 hours. The duration is around 8 to 12 hours. Semilente NPH or Humulin N, 1 to 1.5 hours is the onset. And it will peak. When we say peak, this insulin will spike in the blood during the peak hours. So it will occur at around 5 to 10 hours. Duration is 24 hours. For Lente or Humulin L, onset is around 1 to 2.5 hours. Peak is at 7 to 15 hours, and the duration is the same as that of Semilente, 24. Ultralente or Humulin U, onset is around 48 hours. Peak is at 10 to 30 hours, and duration is around 20 to 36 hours. While Lispro, Humalog, another rapid acting, onset is less than 15 minutes. Peak is around 30 to 90 minutes, and duration is 3 to 5 hours. Why do I want you to remember the peak hours? For people or patients who have type 1 DM, you need to teach them the peak hours on what to do. And what are they going to do during the peak hours? They are going to eat food that is rich in sugar or glucose. Why? These peak hours are the hours when they are going to experience hypoglycemia. Remember, these different types of insulin, um they are going to cause the this insulin will cause the uptake of glucose into the cells. And if that happens, the sugar in the blood will go down, most especially during the peak hours. That's why we need to teach patients when to eat. And usually, for patients who have type 1 diabetes mellitus, we are mixing the regular insulin to the the NPH type of insulin. And when we mix, this is a common board exam question, but it's no longer, this is just for you to know. But this one is no longer practiced because regular and NPH insulin comes in a single vial nowadays, unlike before. But if the board exam or the NCLEX is going to ask you this question, which is the nurse going to withdraw first when mixing these two types of insulin? Will it be regular or NPH? Always remember RN. RN. You're going to be RNs someday once you graduate. R before N first. RN. Regular before NPH first. So if you're going to mix these two types of insulin, you're going to withdraw or aspirate using a syringe, okay? By using a syringe, you need to aspirate the regular insulin first before withdrawing the NPH insulin. Or, because since the regular insulin is the clear insulin, if you're going to check the vial, you will see that this type of insulin appears clear, while NPH appears cloudy. Clear first before the cloudy type of insulin. Okay? And take note of the peak hours. That is when you're going to teach your patients to eat foods that are high in sugar because they are going to feel hypoglycemia during those hours. So, unlike that of type 2 diabetes mellitus, wherein they need to avoid food that are high in carbs or carbohydrates, these patients they need to watch out for the peak hours. And we are going to advise them to carry with them at all times any foods that are high in sugar, such as candy, a chocolate bar, soda, and so on, because they need to take these type of foods during the peak hours. So these are the um, insulin syringes, and you can teach the patient on how to inject insulin on their own. And these type of syringes, they're small, and there's no need for you to teach the patient how to do the correct angle, since this one you can do this in a 90-degree angle. And remember, when injecting insulin, it should be delivered through the subcutaneous route. But these type of syringes, you don't need to make a 30-degree angle in order for you to inject it at the subcutaneous layer, since these are special types of syringes. And the insulin injection sites are the following. You have the upper outer arms, the abdomen, the buttocks, and the upper outer thighs. And we need to advise the patient to rotate the sites for the injection of insulin, or else there will be breakdown on the skin on where the patient is going to apply or inject the insulin. It should not be on a single site only. The site should be rotated every day. Okay? Now we go to the oral hypoglycemic agents. These are the drugs that are given to patients who have type 2 diabetes mellitus, or the adult onset. Now we go to the sulfonylureas. The first generation, or the short acting one, would be tolbutamide or orinase. The intermediate acting first gen would be tolazamide or tolinase. Long acting first gen is chlorpropamide or diabinase. While the second generation, we have glipizide or glucotrol, glyburide, diabeta, glinase or micronase, and glimepiride or Amaryl. What are these sulfonylureas? These drugs bind to the pancreatic beta cells to increase insulin production. Take note, in type 2 diabetes mellitus, they still have insulin, or the pancreas still secretes insulin, unlike that of type 1. In type 1, the pancreas no longer secretes insulin. But for type 2, they still can secrete insulin. The problem is they can only secrete in little amounts. That's why we give them sulfonylureas in order for the pancreatic beta cells to increase the insulin production. And what are the action of each non-sulfonylureas? We also have these non-sulfonylurea drugs. We have biguanides. They act by decreasing hepatic production of glucose from stored glycogen. We have the alpha gluconidase inhibitors. They act by inhibiting the digestive enzyme in the small intestine that is responsible for the release of glucose from the complex carbohydrates in the diet. And the thiazolidinediones, the users of these drugs have a greater risk of heart attack and death, and they decrease insulin resistance and improve blood glucose control. Meglitinides, they stimulate the beta cells to release insulin, which is similar to that of the sulfonylureas. While the DPP inhibitors, or DPP4 inhibitors, they increase the level of incretin hormones, increase insulin secretion, and decrease glucagon secretion to reduce glucose production. We also have glucagon-like peptide 1 agonists. They enhance insulin secretion, increase beta cell responsiveness, suppress glucagon secretion, and slow gastric emptying. And take note, those who are taking glucagon-like peptide 1 agonists, they are given to patients who want to or who wants to do weight loss, since they can reduce the food intake. It can suppress the patient's appetite. One thing more, it slows the gastric emptying, which will make the patient feel full all the time. Amylin analog, they suppress glucagon secretion as well as slow gastric emptying and modulate appetite by inducing satiety. So amylin analogs are also used by patients who want to do weight loss, especially those who are obese. Remember, obesity is also linked to cardiac diseases and as well as diabetes mellitus type 2. So for those obese patients or overweight patients, they can take glucagon-like peptide 1 agonists or amylin analogs in order to suppress their appetite. Because as we all know, food can be pleasurable if you love eating. But the consequences of eating too much food, especially if you're eating too much of delicious fast food, that will make your weight increase. And in order to combat obesity and overweight, you may need these drugs. Glucagon is for the treatment of insulin-induced hypoglycemia. They stimulate glucogenolysis, but these are only given to patients who are experiencing insulin-induced hypoglycemia. So guidelines for oral antidiabetic therapy for type 2 diabetes. Onset of this is around of DM is at age 40 or older, and diagnosis of diabetes should be less than 5 years. Normal that people who have diabetes mellitus type 2 can have normal weight or overweight. Fasting blood glucose is less than or equal to 200 milligrams per deciliter, and less than 40 units of insulin is required per day. And there's normal renal and hepatic function. So these are the criteria for patients in order for patients to um, take oral antidiabetic drugs. Okay, we we have the other non-sulfonylureas, the biguanides, metformin, advantage of metformin or glucophage is that it does not produce hypoglycemia or hyperglycemia. Alpha gluconidase inhibitors, we have acarbose, miglitol, pioglitazone, hydrochloride. We have the miglitinides, we have repaglinide and then nateglinide. The DPP4 inhibitors, we have sitagliptin phosphate, saxagliptin, linagliptin, and allogliptin. Remember the gliptins. They always end in gliptins, these DPP4 inhibitors. We have the selective sodium glucose transporter 2, or canagliflozin. We have amylin analog. Take note of this drug, pramlintide. This can help suppress your appetite, most especially if you have a voracious appetite. Also, with glucagon-like peptide 1 agonists, we have exenatide and liraglutide. They can also suppress your appetite and delay gastric emptying. We also have fixed combination oral anti-diabetic drugs such as glyburide or together with metformin. So I've already mentioned these drugs. So take note, in patients who are taking these drugs, you also need to watch out for hypoglycemia. And if they feel that they are experiencing hypoglycemia, the only one that they need to do is to take a sugar rich food. Now we go to drugs that are affecting blood pressure. First, we have the antihypertensive agents. We have the sympathetic nervous system blockers. I've already mentioned about beta blockers before, such as propranolol. I've discussed that before. We have angiotensin converting enzyme or ACE inhibitors. They always end in pril, ACE, pril, ACE, pril, april, april. They always end in pril, such as captopril and enalapril. What this do is, if you are well familiar with the renin-angiotensin aldosterone system, for that system, renin-angiotensin aldosterone system, if the body is going to detect a drop in blood pressure, the kidneys will secrete renin. This renin will influence now will influence the release of angiotensin 1. But in order for angiotensin 1 to be converted into angiotensin 2, it needs angiotensin converting enzyme or ACE. That enzyme will convert angiotensin 1 into angiotensin 2. What does angiotensin 2 do? Angiotensin 2 causes vasoconstriction. So if it causes vasoconstriction, it will increase the blood pressure. Take note, like that of a water hose, if you further block the water from coming out of the water hose, what happens to the water pressure? It increases. The water becomes more propulsive. So that's also true with our blood vessels if it constricts. Aside from that, angiotensin 2 will in turn influence the adrenal glands, the adrenal cortex, to secrete aldosterone. What does aldosterone do? Aldosterone in turn influences the kidneys to retain water, or sodium together with water, of course. In turn, increasing the blood volume, further increasing the patient's blood pressure. So, in order for angiotensin 1 not to be converted into 2, this drug, angiotensin converting enzyme inhibitor, when we say inhibit, it stops it. So it will no longer be converted to angiotensin 2. We also have angiotensin 2 receptor blockers like candesartan, eprosartan, olmesartan. They always end in sartan. Take note of that. Calcium channel blockers, they always end in dipin, such as amlodipine, nifedipine, and nicardipine. We also have vasodilators such as diazoxide, hyperscat, hydralazine. This is the drug of choice for pregnant women who are suffering from pregnancy-induced hypertension. We also have nitroprusside or nitropres. Nursing interventions, make sure to monitor or check the blood pressure before giving these antihypertensive drugs. Most likely the vasodilators. So you need to check for the patient's blood pressure. Monitor the heart rate of the client as well. And since these drugs can lower the blood pressure of the patient, you expect that orthostatic hypotension may be present. So you need to assist the patient when the patient feels dizzy from sitting to a standing position. So in order to avoid that from happening, we need to instruct the client to slowly rise from the bed or from a chair because orthostatic hypotension can happen. Now we go to the cardiotonic agents. These are drugs that are used to treat congestive heart failure, and examples are vasodilators, diuretics, beta adrenergic blockers, or agonists rather, and cardiac glycosides. But we'll focus more on cardiac glycoside here. Digoxin or lanaxin is the drug of choice for congestive heart failure. And what does it do? It has several effects on the heart. First, it increases the force of myocardial contraction or myocardial contraction. This is known as a positive inotropic effect. Take note, for patients who have heart failure, their heart beats like this. It's fluttering. It doesn't beat well. If that happens, blood that will circulate is lesser in amounts. The cardiac output would be lesser if the heart pumps in this manner. And this drug, digoxin, it will improve the pumping ability or the contraction of the heart of patients who have heart failure. So it will increase the cardiac output. It increases cardiac output. This is what I'm talking about. And renal perfusion, which has a diuretic effect. And take note, for patients who have heart failure, since the heart is compensating for the inadequate volume of blood circulating in the body, since it beats like this, you can detect that the heart rate is increased. Since it will try to compensate, it will slow down the heart rate now into a normal rhythm. And so it has a negative inotropic effect. Negative inotropic effect. And it will decrease the conduction velocity through the AV node. Remember the conduction system of the heart? So the firing of the neurons in the heart will slow down in order again to reduce the heart rate. So it has a negative dromotropic effect. This is what digoxin does. Nursing interventions, before giving this drug, make sure to check the patient's heart rate before taking or before the patient will take the drug. Withhold the drug if the patient's heart rate is less than 60 beats per minute. You need to monitor the serum digoxin level as well. It should be at around 8.8 to 2 nanograms per milliliter. Some books they say 0.5 to 2. The book that I have based this from is 0.8 to 2 nanograms per milliliter. Prepare its antidote digibind in case of digoxin toxicity. What are the signs and symptoms of digoxin toxicity? You have headache, weakness, drowsiness, and a yellow halo around lights. So if the patient will see circles around lights, the patient's already suffering from the toxicity from digoxin. So prepare digibind if you have observed any of these from the patient. Now we go to the anti-anginal drugs. Drugs for angina. What's angina? Angina is chest pain caused by coronary artery disease. What happens in coronary artery disease is that there is a blockage in the coronary arteries of the heart. And if that happens due to the plaque formation, plaque will be formed due to high fat diet in the patient's food intake. And those plaque will obstruct the blood flow to the cardiac muscle. And if that happens, the patient will feel chest pain every now and then due to the um, diminished blood supply to the myocardium. So that will happen if the patient's heart does not receive enough blood due to the blocked or obstructed coronary arteries because of that plaque formation. And what are drugs for angina? So that chest pain. The chest pain will be felt here at the left substernal border here. And it may radiate to the left shoulder, left neck and jaw, left arm. So the that's the signs of having angina. And the drug of choice for patients who have angina pectoris would be nitroglycerin or nitrostat. And if they are diagnosed to have coronary artery disease, that's why they have angina, we need to teach patients to take the drug once they have experienced chest pain. But if the chest, and this nitroglycerin, it's fast acting. If they still are, if they haven't felt relief from nitroglycerin after 5 minutes, they are going to take the second dose. If relief is not yet felt after 5 minutes, they are going to take the third and final dose. They can only take nitroglycerin 3 times. First time, if they feel chest pain. If not relieved, second dose. If not yet relieved after 5 minutes, second dose. So there should be a 5 minute span in between these 3 doses. But after 5 minutes, 5 minutes after the third dose, the patient still is not relieved from pain. The patient should call his or her doctor or should call for an ambulance. Why? The patient is no longer experiencing angina, but the patient is already experiencing myocardial infarction, which is a complication now of coronary artery disease. Why? What has happened? There is total occlusion now of a coronary artery. The patient is experiencing a heart attack. So if that happens, that is already an emergency. They need to call for help, call for emergency services from the hospital, from the doctor. Other drugs for angina would be beta blockers and calcium channel blockers. But take note of the frequency of giving this drug. Take it. And we need to advise patients who have nitroglycerin or have angina to take nitroglycerin with them at all times. If they're going out of the house, that drug should be with them. And advise them to keep the drug in a dark container because this drug is photosensitive. The drug will be deactivated by light. So make sure to keep the drug away from light, or else the drug is going to be deactivated by light. Now we go to lipid lowering agents. These are drugs that will lower the serum LDL levels or low density lipoproteins. Remember, low density, low hell, high heaven. High density is good cholesterol, low density is bad cholesterol. And these are our statins. They always end in statin, like atorvastatin, fluvastatin, lovastatin, pravastatin, simvastatin. These drugs block the formation of cellular cholesterol. So, if you have a patient who has a serum cholesterol levels of more than 200 milligrams per deciliter, they need to take this because having high cholesterol levels can increase the blood pressure and can predispose the patient to have coronary artery disease. Now we go to drugs affecting blood coagulation. We have these antiplatelet drugs. We have aspirin, clopidogrel, dipyridamole, and ticlopidin. Other we also have anticoagulants, warfarin and heparin. When there is toxicity of both drugs, what are indicators where these drugs are, or if the patient is experiencing toxicity of these drugs, if the patient is already bleeding. So if are any forms of bleeding signs, such as um, gum bleeding, nose bleeding, what else? Blood from the stools, we need to give the antidote. And take note, warfare, the antidote, remember HPCK. Harry Potter wears Calvin Klein. What does that stand for? HPCK. In order for you to remember HPCK or Harry Potter wears Calvin Klein, HP, heparin, the antidote for heparin would be protamine sulfate. So HP, heparin, protamine sulfate. While for Coumadin K, Calvin Klein, Coumadin K vitamin K is given as an antidote. One thing more, if you are giving heparin, the lab value that you should monitor would be the PTT, or the partial thromboplastin time. This is the rules of 10. Rule of tens. Remember, heparin has 7 letters. It has 7 letters. So 7 plus PTT. PTT has 3 letters. Partial thromboplastin time. If you are giving heparin, you monitor for PTT, or partial thromboplastin time. But if you are giving warfarin, warfarin has 8 letters. 8 letters. You monitor PT, or the prothrombin time. PT has 2 letters, prothrombin time. So warfarin, PT. Heparin, PTT. Now we go to the thrombolytic agents. They either end in place or ace, like alteplase, reteplase, streptokinase, or urokinase. What are these drugs used for? These drugs will dissolve emboli or embolus that has formed, and they are used for the treatment of myocardial infarction, pulmonary emboli, and ischemic stroke, because these conditions, they have formed embolus that is blocking or occluding a blood vessel. And in order to dissolve these blood clots, we need to give any of these drugs. Now we go to the diuretic agents. When we say diuresis, it means this will induce urination. So for diuretic drugs, these are drugs that will induce or increase the patient's urine output. Now we go to the thiazide diuretics. Action is to block the chloride pump, which in turn excretes both sodium and chloride together with water. Examples of thiazides would be hydrochlorothiazide and chlorothiazide. Take note, they end in thiazide. We have loop diuretics. These drugs block the chloride pump in the ascending loop of Henle. Remember, these drugs, their site of action is particularly at the loop of Henle in each unit of the kidney, which are the nephrons. So specific site is the ascending loop of Henle. Examples of these are furosemide or Lasix, which is the popular one, bumetanide, Bumex, and torsemide. And take note, these drugs, they are potassium wasting diuretics, meaning they excrete potassium in the urine. So you need to watch out for the potassium levels of, or the serum potassium levels of the patient when giving loop diuretics, such as furosemide. We have carbonic anhydrase inhibitors. They block the effect of carbonic anhydrase, which is an enzyme that will slow down the movement of hydrogen ions. As a result, more sodium and bicarbonates are lost in the urine, such as acetazolamide, this used to treat glaucoma, and methazolamide, also for glaucoma. So this has nothing to do with the kidneys, but more of the eyes. Next, we have osmotic diuretics. They pull large amount of fluid into the urine. Examples are glycerin, isosorbide, mannitol, and urea. These drugs, and like the loop diuretics, they're given to patients who are also experiencing edema or who are experiencing hypertension in order to decrease the blood volume. This one, osmotic diuretics, they're also given to patients who are experiencing edema. And most likely, these drugs, they are given to patients who are experiencing cerebral edema. So example, if the patient has experienced a head trauma brought about by motor vehicular accident or a fall, or if the patient has meningitis or encephalitis that causes the brain to swell or the meninges to swell, or because of the accident, any part of the CNS swells, the doctor will prescribe osmotic diuretics in order to avoid the swelling of any area of the central nervous system. Because swelling of any area of the central nervous system, such as the brain itself or the meninges, will cause increase in intracranial pressure. And in order for that to be avoided, the doctor is going to prescribe osmotic diuretics. So, nursing consideration when giving diuretics, always check the blood pressure before administering the diuretic because this will further decrease the BP. Monitor the patient's blood pressure when giving diuretics and monitor the patient's INO or intake and output. So monitor the fluid intake, how many how many glasses of water the patient takes in every day, or how much amount of fluid has been delivered through IV, like the IV fluids of the patient, and the urine output. Is the patient has a urine bag from the patient's catheter? You need to check the urine bag since there are graduations there for milliliters. But if the patient doesn't have a urine bag, you ask the patient how many times the patient has voided during your shift. And you're just going to make estimations from there. Now we go to drugs that are affecting the respiratory system. First, we have the antitussives. These are drugs that will suppress the cough reflex. So these drugs are helpful for patients who are experiencing cough. Caution patients not to drive or operate heavy machinery when giving antitussives because they can cause drowsiness. Examples are codeine, hydrocodone, and dextromethorphan. So these are examples of antitussives, but these antitussives, they are not over the counter. You need a prescription because these drugs, especially codeine and hydrocodone, they both are highly addictive. We have decongestants, topical decongestants. We have ephedrine, oxymetazoline, tetrahydrozoline, and xylometazoline. When we say topical, these can come in nasal spray forms. So if you have a stuffy nose due to allergic rhinitis or whatsoever, you can have your physician prescribe you a topical decongestant or a nasal spray that contains any of these drugs. Ephedrine is very, very popular as a nasal spray, but that is not very common here in the Philippines. It's more common in America. For oral, we have pseudoephedrine as a decongestant. We have antihistamines. These block the effects of histamine 1 receptor sites, which will decrease allergic response. Again, when giving antihistamines, we need to advise patients not to drive and operate dangerous machinery again because antihistamines can cause drowsiness. Examples of antihistamines would be diphenhydramine, the popular one, Benadryl. We have promethazine or Phenergan. This one, though, is non-drowsy. Loratadine, Claritin, is non-drowsy. We also have chlorpheniramine or Alerchlor. These are the common drugs or antihistamines. We have also cetirizine. What else? There are various forms of antihistamines that you can have. And these drugs, they are used to treat allergic reactions from drugs or food. If you have allergies in seafood, chicken, egg, other kinds of foods or drugs, you can take antihistamines for allergic reactions. Next, we have expectorants. This will enhance the output of respiratory fluids by reducing the adhesiveness and surface tension of these fluids, allowing easier movement of the less viscous secretion. What does these do? This that's why it's known as expectorant. It will facilitate easy expectoration of what? Of phlegm. If you have hard to expectorate phlegm, if you're having a hard time removing it from your respiratory system, expectorants can help loosen them up in order for you to expel them out of your respiratory system by hacking it out of your airways. Example would be guaifenesin or Mucinex. I think the brand name of guaifenesin here in the Philippines is Robitussin. We also have mucolytics. These are usually reserved for patients who have difficulty mobilizing and coughing secretions. So it's like the same as that of expectorants. It will lyse or it will lyse the stubborn mucus. It will dissolve the mucus that is hard to expel out of the airways. Example would be acetylcysteine or mucomist or Dornase alpha. Take note, acetylcysteine is also the antidote for acetaminophen toxicity. Now we go to drugs that are used to treat obstructive pulmonary disorders or drugs that are intended for the lower respiratory tract, most likely that of the lungs, the tracheobronchial tree, most especially. We have the bronchodilators or the anti-asthmatics. They have a direct effect on the smooth muscles of the bronchi. So what do these drugs do? They dilate. They cause relaxation of the smooth muscles on the bronchi. Remember those rings that are surrounding each bronchi? These are smooth muscles. And if they are constricted or if they contract, it will cause bronchoconstriction. So these drugs, they cause relaxation of those smooth muscles in order to bronchodilate the bronchi. Example would be aminophylline, theophylline, and caffeine. But take note, these drugs are sympathomimetics. They can bronchodilate constricted bronchi, but take note of its side effect. Watch out for tachycardia. Sympathomimetics, I've already discussed them to you before. We have albuterol, ephedrine, epinephrine, isoproterenol, levalbuterol, and terbutaline. They mimic the signs of sympathetic nervous system stimulation. Next, we have leukotriene receptor antagonists. These drugs block the signs and symptoms of asthma. Take note, if the patient has asthma, there are certain triggers to asthma, such as allergens. And if these patients are exposed to these allergens, their overreactive respiratory system will react to that allergen. And the mast cells found in the respiratory system will secrete chemicals that will cause the constriction of the bronchi. It's a protective mechanism against foreign substances that are trying to invade the respiratory tract. One mechanism is bronchoconstriction. This will avoid the entrance of foreign substances into the lungs. But due to the hyperreactive respiratory systems of asthmatic patients, they will secrete these substances, or these mast cells will secrete these substances, causing bronchoconstriction. And what are these substances? We have histamines. That's why we also have antihistamines. Histamines, bradykinins, other kinins, and leukotrienes. Leukotrienes can cause bronchoconstriction as well. And what are examples of leukotriene receptor antagonists? We have zafirlocast, montelukast, zileuton, or anything that ends in leucast. These are leukotriene receptor antagonists. Popular here is montelukast. Um, my son is taking this whenever he has asthmatic attacks. We have mast cell stabilizers. Like what I've mentioned earlier, mast cells are responsible for secreting these chemicals that can cause asthma. So they inhibit the release of histamine from mast cells, such as cromolyn and nedocromyl. Next, we talk about drugs affecting the GI secretions or gastrointestinal secretions. We have histamine-2 antagonists. These drugs reduce gastric acid secretions. Unlike that of histamine 1, which is for allergies, histamine 2 is responsible for the secretion of hydrochloric acid in the stomach. And in order to block histamine 2, and in order to block the process of producing hydrochloric acid in the stomach, we are going to give these drugs. These drugs are given to patients who have ulcer or experiencing hyperacidity, or they can also be given post-op or pre-op rather, pre-operatively in order to reduce gastric secretions that can regurgitate. Example of these drugs would be cimetidine, ranitidine, famotidine, nizatidine. They always end in tidine. Popular here is ranitidine or Zantac. So if you're experiencing hyperacidity or if you have ulcer, you can be given these drugs. We also have antacids. Unlike that of histamine 2 antagonists or proton pump inhibitors, which has a direct effect in the suppression of hydrochloric acid, antacids, they neutralize hydrochloric acid. Example of antacids would be sodium bicarbonate, calcium carbonate, or TUMS is the brand name, magnesium salts, and aluminum salts. Now, take note. There are certain side effects of these drugs. Magnesium salts or magnesium hydroxide can cause constipation. So for patients who are taking magnesium hydroxide antacids, warn them about the side effect constipation because they might experience that. But for patients who are taking aluminum salts or aluminum hydroxide, it's the opposite of magnesium hydroxide. Aluminum hydroxide can cause diarrhea. So diarrhea. We have a drug, a brand name here in the Philippines that combines both of these drugs in order to cancel out each other's side effects. So so that the patient will no longer experience constipation or diarrhea from both of these drugs. So they are combined. So since they are combined, they cancel out each other's side effects. Magnesium hydroxide plus aluminum hydroxide together with simethicone. What is the brand name of that drug? It's very, very common. It's also commonly advertised on TV. It is Kremil S. So Kremil S is a combination of magnesium hydroxide, aluminum hydroxide, and simethicone. What is simethicone for? Simethicone is not an antacid. That component of Kremil S is used to treat flatulence because it will break up the gas bubbles that have formed in the GI tract. So if you are experiencing flatulence, you can also take Cremeles. So if you feel that you're bloated due to air or gas buildup in your GI, you can take that. Now we go to proton pump inhibitors. This suppresses gastric acid secretion by inhibiting the potassium adenosine triphosphate enzyme, which is needed. This enzyme, the potassium adenosine triphosphate, it is needed in the final step of hydrochloric acid production. The histamine-2, it's needed for the first step in the production of hydrochloric acid. But for proton pump inhibitors, or this enzyme, potassium adenosine triphosphate, it is needed for the final step of hydrochloric acid production. Examples, or before we proceed to the drugs, they always end in prazole. Prazole. Example would be omeprazole, esomeprazole, lansoprazole, pantoprazole, and rabeprazole. But the common one here that is taken by patients in the hospitals that we have would be omeprazole or Prilosec. Next, for patients who have duodenal ulcer, we have this antipeptic agent. Protect eroded ulcer sites. So it will create a film. So if the patient has ulcers in the GI, this drug, sucralfate or carafate, will um, will create a film, a barrier above the ulceration in order to protect it. Take note the time of administration or when we are going to give this drug to the patient. Sucralfate is given before meals. Take note, before meals. If you give sucralfate after meals, it is going to be useless. Why? Sucralfate is given in order before meals in order to provide that filmy substance above the ulceration. That's why after the patient has taken sucralfate, that's the time the patient will eat. Now, during eating, the stomach will automatically produce hydrochloric acid. And that hydrochloric acid will contribute to the pain that is being felt by patients who have duodenal ulcers. And if you give this drug before meal, after meals, there's no protection in the ulcerations because once the patient eats, hydrochloric acid will be produced. That acid will go into the ulceration and will cause pain on the patient. But if you give it before meals, that ulceration is protected first before the hydrochloric acid will go to that ulceration. So that film or that filmy substance will protect that ulceration from the hydrochloric acid and it will promote healing. It will promote healing of those ulcerations. We have anti-ulcer drug, misoprostol or Cytotec. But take note, this is no longer, it's banned here by the FDA in the Philippines. Why? Initially, this is used or it's indicated for NSAID-induced gastric ulcer to decrease the signs and symptoms of the disease. For gastric ulcers or peptic ulcers. But This drug is being used as an abortive patient. When we say abortive patient, it will cause the pregnancy, or it can cause abortion in pregnant women. That's why its category is pregnancy category X. Never ever give this drug to pregnant mothers since it will cause spontaneous abortion. Next, we have digestive enzymes, saliva substitute, mouth coat, or salivart. They help dry mouth in stroke, radiation therapy, chemotherapy, and other illnesses. They can be given before, during, and after meals, together with pancreolipase. Pancreolipase or pancrease is given to patients who are experiencing pancreatitis. Take note, in pancreatitis, the patient cannot um, secrete the pancreatic enzymes. Why? Because of the inflammation of the pancreas will constrict the pancreatic duct. So if it's constricted, there will be no outflow of the pancreatic enzymes. Or this can also be helpful for patients who have cystic fibrosis. You will learn more about cystic fibrosis later on, or CF. So this will aid digestion and absorption of fats, proteins, and carbohydrates for patients who have pancreatitis or cystic fibrosis. Next, we have laxatives or antidiarrheal agents. Laxatives. Laxatives are the following. Oh, sorry, I kind of mixed up magnesium sulfate and magnesium hydroxide rather, and aluminum hydroxide. Magnesium hydroxide is the one that causes diarrhea. Sorry, while aluminum hydroxide is the one that causes constipation. So for laxatives, we have castor oil. They should not be used during pregnancy since it can cause premature labor. So it's one of the oldest forms of laxatives, this castor oil. Others we have, this is common here in the Philippines, bisacodil or dulcolax with the magnesium sulfate, magnesium hydroxide, which can also be used as an antacid, lactulose or cronulac, psyllium or metamucil, docusate, colase, and mineral oil, agral plain. So they are used for the short-term relief of constipation and to prevent straining when it is clinically undesirable. Any of these drugs can be given to patients who are pregnant, but or except for castor oil. Now we go to gastrointestinal stimulants. We have dexpanthenol, metoclopramide, and domperidone. They will increase GI activity and promote secretions. What do? If you have indigestion, for example, if you ate too much food, this can paralyze your GI tract, meaning there will be limited motility in your GI due to ingestion of too much food. So, in order to ease the feelings of indigestion, you can be given any of these drugs, such as domperidone or motilium. That's also one of the popular drugs here in the Philippines. But for metoclopramide, you can also use that as an antiemetic. So if you feel that you are nauseous, if you have nausea and vomiting, you can be given this metoclopramide. Next, we have antidiarrheal drugs. We have bismuth subsalicylate, pepto-bismol, drug of choice for patients who have traveler's diarrhea. Traveler's diarrhea, it happens if you go to a remote area where they have unclean water, unclean food. You can have this. We have common one here in the Philippines is loperamide or Imodium, or opium derivatives, Paregoric. But these opium derivatives, they are no longer being given since they are also addicting. Remember, opium derivatives can also cause constipation. That's why they are also being used as an antidiarrheal drug. But they are no longer used as antidiarrheals because they can be addicting. So loperamide is used instead. Aluminum hydroxide can also be here because aluminum hydroxide causes constipation. Next, antiemetics. These are drugs that are used to treat patients who are experiencing frequently vomiting, especially those who are having chemotherapy. They are also given for the treatment of motion sickness. We have over-the-counter antiemetics like dimenhydramine, dramamine, cyclizine, antivert, and diphenhydramine hydrochloride or Benadryl. Benadryl can also be used as an antiemetic. But for prescription antiemetics, we have hydroxyzine, promethazine, scopolamine, flucloperazine maleate, metoclopramide, trimethobenzamide hydrochloride, and aprepitant. So these needs prescription. Next, we have the serotonin or 5-TH3 receptor antagonists. They always end in cetron, such as dolacitron mesylate, ganicitron, ondansetron, and palonocitron. These drugs are specifically given to patients who are experiencing nausea and vomiting due to chemotherapy. So serotonin receptor antagonists are given instead, such as these cetron drugs. Cannabinoids, that's one of the new things that are being used for cancer patients. Cannabinoids, such as dronabinol, this is the active ingredient in marijuana. It is used for the treatment of nausea and vomiting in chemotherapy. That is why medical marijuana is used in other countries, except for Canada, because Canada already is using marijuana for recreational purposes. But other countries, they use medical marijuana for the treatment of nausea and vomiting in chemotherapy. But here, this one's not yet legal. This one's not yet authorized by the Food and Drug Agency here in the Philippines. Next are emetics. These are drugs that are used to induce vomiting or emesis due to consuming toxic substances, such as Ipecac. It's an emetic drug. It will induce vomiting. It should be taken with a glass of water and do not give milk or give it together with milk or carbonated beverages. Usually, Ipecac comes in fluid forms. But do not use emetics in patients who have ingested corrosive substances such as gasoline or acids because it will further damage the patient's esophagus. So never ever give emetics such as Ipecac to patients who have ingested corrosive substances. Why? If you induce vomiting in patients who have taken in corrosive substances, it will damage the esophagus further. Damage has already been done due to the ingestion of corrosive substances. But if you induce vomiting, it will go up again, further damaging the esophagus. Now we go to drugs for men's health and reproductive disorders. We go first to androgens, which are the male sex hormones. Testosterone is indicated for patients who are experiencing hypogonadism. If you know a male who did not undergo puberty, didn't grow tall, they didn't develop the Adam's apple, their voice did not deepen, they may be experiencing hypogonadism. So, in order to treat that, they might be given testosterone or synthetic androgens such as danazol, methyltestosterone, android or methyltest, or fluoxymesterone. We also have anabolic steroids, oxandrolone or oxandrine. These drugs are also abused by what? By whom? They are abused by bodybuilders. And these drugs are injected by bodybuilders in order to increase their muscle mass. But taking too much of these androgens can be very dangerous. Why? Some of them, um, or they, some can cause complications of the heart. from taking too much androgens, or they can cause hypogonadism as well. Why? What will happen? The testes of us males, if we are taking too much androgens, will detect that there's testosterone circulating in the blood. The testes will no longer secrete testosterone, and it will shrink. The testis will shrink. And if the testis shrinks, it will no longer produce sperm, or it will produce lesser sperm. That's why people who are injecting androgens in order to increase their muscle mass have a low sperm count. So be warned. If you plan to bodybuild someday and plan to inject any of these androgens here in order to increase your muscle mass, those can be the consequences: heart problems or the shrinkage of your testes. Next, we have drugs for erectile dysfunction or impotence. So if you have impotence, impotence is very common in males who are 40 or older, 40 to 50 or older. And these drugs will help maintain the erection in males who can no longer maintain the erection. Examples are sildenafil or Viagra, which is the most popular drug for erectile dysfunction. It works best on an empty stomach. We also have tadalafil, Cialis, or vardenafil, Levitra. Caution patients who have hypertension or any cardiac problems, because these drugs are a big no-no to those patients. So patients who are experiencing hypertension or cardiac problems should not be given any of these drugs, because it will further increase their blood pressure, or it can further complicate their cardiac problem. So if you have, that's it, everyone, by the way, for pharma. Thank you very much, class, for attending to all of my video lectures for this semester under pharma. And I hope that you have learned a lot from the lessons that I have provided you. I hope that you have enjoyed all of the lessons that I have given you for this past semester. I know it has been a very, very trying, a very hard semester for all of us due to the pandemic that still is occurring up to this point. But I hope I've taught you a lot under pharma. Always take note of the drugs that the importance of the drugs, different drugs that I have taught you over this semester, because you will bring these drugs over to your next subjects when you are already in your third year, which is medical surgical nursing. So if you have any questions about the lecture that I have done today, please do not hesitate to ask me through Messenger or through any other forms. And again, a big thank you to all of you who listen to my video lectures. I'm hoping for everyone to pass this semester, and I hope that you will all be registered nurses by the time that you graduate. Thank you, and good luck to everyone on your final exams. God bless to all of you. Have a great day. Thank you very much.